I mean, one of the questions that came up earlier, which I should have tried to answer, which I thought was interesting, but obviously it kind of illustrates the issue about abdominal scanning, is someone said there have been some incidences of intrauterine pregnancies misdiagnosed as non-ruptured ectopics diagnosed abdominally, and how do you avoid this? And I can kind of see that with abdominal scan. You stick the probe on, if there's a big ectopic, you kind of might think that's it, that's the uterus or something. But and I answered it in writing saying, well, I think use vaginal ultrasound and also appropriate training. But maybe that's being a little bit glib. I wonder what your feelings are.
Yeah, I must admit, my experience of women with kind of advanced ectopic pregnancies that have been missed have often been missed because their first scan has been maybe their 12-week scan, and someone's put the probe on, seen the pregnancy, and assumed, yes, that's the uterus. So, yeah, I suppose the key is that you always go back to basics with your scanning, and you always want to be getting a longitudinal view of the uterus to begin with and following it down to the cervix. And then you should be able to then see whether your pregnancy is within the endometrial cavity of the uterus.
No, I think you're right, because even with abdominal, you should be able to angle it down and see the cervix and follow it down. So as long as you don't make assumptions, you should be able to avoid that, shouldn't you? Really?
Absolutely. And I mean, it's like the same thing as well when you immediately put a probe on, you go, oh, that's in the uterus, but actually it's an ectopic. It goes the other way around as well. Yeah.
No, I mean, I can see how it happens, but it shouldn't, I suppose.
No, I think that's why we just always say to people, whenever you're doing a scan, you ignore the pathology, go for your basics, always look at the uterus first and follow it down to the cervix.
Well, I always, when someone says someone's got X, almost try and look at the normal stuff first, because I always know it's so easy to get distracted and so focused. I mean, I'm sure, well, I have anyway. I know that I've focused on, someone's been sent to me with, please scan this woman with a cyst, and I've suddenly looked at the report and realised I've forgotten to actually scan the uterus properly. And it's kind of deeply embarrassing, because I have to say, could you just pop your things back on again, please? Sorry, off rather.
Yeah, no, absolutely. I mean, sometimes when you put the probe in and you can see it's obvious ectopic, it's like, ignore it, measure the endometrial thickness, look at the other ovary first, then come back to that side. Yeah,
right, exactly.
Absolutely.
Emma, we're going to have to go on to some cases. Thanks for for logging in just for this bit. I know you're very busy, and
no, I'm enjoying listening to it all. So thank you, everyone else. Yeah.
Okay. Well, thanks for having it. Thanks for coming. We're going to move on to some cases. I'm very pleased to introduce my colleague, Maya Almamar, who's there, who's consultant at Imperial College in London, and Alex Novak, who is doing his PhD in Imperial College as well. And they're going to talk about some cases, hopefully illustrating some of the issues we've raised. Maya's obviously got that virtual background that makes her look like she's busy in a clinic. And we don't fall for that. We don't fall for that one. We've all got that background.
Anyway, I've been working really hard.
Well, I'm glad. Good. Someone's seeing the patients. That's good to know. All right, over to you guys.
Thank you.
So if we go on to the first case, we have a 39-year-old lady who is in her first pregnancy at 7 weeks and 2 days pregnant by her last menstrual period. She had spontaneous conception, but she was under investigation by the local fertility unit and was referred with a possible miscarriage. They'd measured a CRL of 11 millimeters and no fetal heart. On the initial ultrasound at the early pregnancy unit, an intrauterine gestational sac and yolk sac were visualized. The CRL measured in the fertility clinic, although in some views could represent a fetal pole, on closer inspection resembled a chorionic bump with a separate, much smaller fetal pole. Because of this, the diagnosis was made of a pregnancy of unknown viability, and a repeat scan was scheduled in 7 days. On the next image, the day 7 ultrasound showed a viable intrauterine pregnancy with a separate chorionic bump. So on the next slide, I wanted to talk about the diagnosis of miscarriage. In 2011, this paper was published, which we discussed earlier, which led to an alteration in the diagnostic criteria of miscarriage to what we have now, which reduced the risk of false positive diagnosis of miscarriage. One of the first errors in diagnosing miscarriage can be measuring the gestational sac. It's very important that we take 3 measurements of the gestational sac, both in the transverse and longitudinal views, to gain a mean gestational sac diameter. It's important not to take the longest measurement in isolation to diagnose miscarriage. If a gestational sac is visible only and its mean measurement is less than 25, then it should be measured in 2 weeks. If a CRL is present without a heartbeat and is less than 7 millimeters, again, there should be another scan in 1 week. If able to diagnose miscarriage, then it is gold standard for a second person who's qualified in scanning to come in and confirm the diagnosis. On the next slide, we have a table, again, reiterating the correct diagnostic criteria of miscarriage and its validating paper, but also a chart of findings that are suspicious of miscarriage. Maya, what are your thoughts on the soft markers of diagnosing miscarriage?
Yeah, I mean, I think the first thing is this case really highlights how important it is to be really careful and have these stringent rules and follow them when we're diagnosing pregnancy failure. So other soft markers, if you like, or things that might make you suspicious of a pregnancy loss have not been validated in such a stringent way and are not part of diagnostic criteria. So things like the empty amnion or chorionic bumps. So, okay, we can notice them. They might be useful or in terms of triage, but I'm afraid they're really not validated or really not studied appropriately. So I would keep things simple and stick to the diagnostic criteria that have been validated in thousands of patients in a multi-center fashion. And that makes things much easier. It was an interesting question from the audience about transvaginal ultrasound, because all of these, guidelines and rules in these papers have all been created for transvaginal ultrasound. So when we are using transabdominal scan, obviously our images are not going to be quite as good. So where there is doubt, it's so much better just to bring the patient back and leave an even longer gap. So where possible, 2 weeks. That would be my general feeling. I think you might agree, Alex.
Yeah. Okay, so we'll move on to the second case. It's a 29-year-old who is in her third pregnancy with 2 previous vaginal deliveries at around 6 weeks and 4 days by her period date. She presented with 5 days of light vaginal spotting. As we can see on these ultrasound image, in the first image, you can almost try to trace the pregnancy location through the menstrual line and cavity, but there are definite concerns here on the location of this pregnancy and whether it's in the interstitial portion of the tube. We can see both ovaries are visualized and there were no concerns about nexal masses at this point. With TV ultrasound, further advances have now led us to have 3D ultrasounds. And as you can see in this image, the pregnancy does indeed look as it's to appear as it's in the endometrial cavity. And again, if we rescan and use 3D imaging, we can see this pregnancy centralized into the endometrial cavity. I think the important part of these images is to note, if you are unsure on the location of the pregnancy, don't make a diagnosis on that initial scan. Re-image at a later date or refer a patient to a centre with expert scanning facilities. In this third case, there's a 38-year-old patient who's 8+5 by dates. It's her second pregnancy of a previous vaginal delivery, and she presented with lower abdominal pain and 1 day of vaginal bleeding. She had no past medical history. We look at her initial scan. On the next slide, there is a thickened area which is slightly cystic endometrium. Both ovaries are seen with no obvious adnexal pathology. An HCG and progesterone were taken and follow-up was planned as per the M6 model that we use in our centre. There were concerns due to the appearance that this could either be a hydropic miscarriage or possibly a molar pregnancy on the first ultrasound, but her HCG returned at over 56,000 with progesterone of 17. And due to these concerns, she underwent surgical management of miscarriage. It was noted during surgery that minimal pregnancy tissue was seen, and the histology 2 weeks later confirms no trophoblastic or chorionic villi were identified. Although an incorrect suspected diagnosis was made, it is important that the histology was chased promptly and recognised that a pregnancy hadn't been identified. She was brought straight back to the early pregnancy unit where repeat HCG and ultrasound took place. The HCG was 9,023, and if we go to the next image, we can see at this time we saw a mass with a cystic area in the center in keeping with a suspected interstitial pregnancy. Measured around 40 millimeters and was also further characterized in 3D imaging. We can see here clearly that the pregnancy mass is outside of the uterine cavity. Again, there's diagnostic criteria, including visualization of an interstitial line and the continuation of the myometrial mantle around the ectopic sac, but as we've discussed previously, this hasn't been fully validated. Due to her falling HCG and already having 2 weeks of expectant management from the date of her surgery, she had continued expectant management with close HCG follow-up over the next 2 months. The next ultrasound image shows the mass on an interval scan, which has reduced in scan. And there are also some papers here looking at both the diagnosis and expectant management of interstitial pregnancy. May, do you have any other consideration on choosing the correct management of interstitial pregnancies?
I mean, it's really a difficult one. And again, you know, exactly, Emma gave a really good, you know, guidelines as to what we consider. So obviously patient factors, scan factors, and surgical factors, and of course, local factors. But I think in terms of interstitial pregnancies, if you're able to, and the HCG is falling and a patient is clinically well, expectant approach is safe in those circumstances. There are papers on the use of methotrexate in this, and again, another way that has been shown to be successfully treat interstitial pregnancies. Surgery, obviously, particularly in a low resource setting, because of the challenges of bringing women back, may be preferable. But the problem with surgery in pregnancies is that you're doing a corneostomy, so whether that be a laparoscopic or a laparotomy, to excise the interstitial pregnancy mass from the interstitial portion of the tube, you have to remove some of the uterine cornua. And that can be very damaging to the uterus, with a risk of hysterectomy and, of course, risks in future pregnancy like uterine rupture. And there are a number of kind of papers published looking at several cases of interstitial pregnancy treatment by surgery and follow-up in subsequent pregnancies that have demonstrated these risks. So it's very challenging to manage, and we just have to be aware that surgery maybe has its future complications.
Great, thank you. So the next case, we have a 28-year-old who's 6 weeks and 5 days. It's her 4th pregnancy with previous miscarriage and 2 previous terminations of pregnancy. She presented with pain and bleeding. If we go to the first scan, we can see a thickened endometrium of around 10 millimeters. Both ovaries were visualized and no adnexal masses seen. This was classified as a pregnancy of unknown location, and so an HCG and progesterone were taken. These were then put into the M6 model, which recommended repeat in 48 hours. In our unit, we also get a second scanning proficient person to confirm the diagnosis and try to reduce operator error. We can see here the 48-hour HCG only had a slight increase of 1,248. This was then again inserted into the M6 model, which gives us the following risk stratification. You can see here the risk of ectopic is 49.3%, of a failing pregnancy of unknown location 26%, and a possible intrauterine of 24.9%. The model stratifies at less than 5% risk that this is low risk, but these patients are also safety netted with a pregnancy test at 2 weeks. It can also be useful to allow approximately 15% of patients to be discharged from the first PUL scan with a pregnancy test in 2 weeks. It will also stratify other pregnancies into low risk for ectopics and recommend a scan in 1 week and reduce the need for multiple blood tests and attendances. Because of the findings, we called her back for a scan on the same day. And if we go to the next image, we can see, again, the thickened endometrium is seen, a normal looking right ovary. And then in the next slide, we can see the left ovary with a mass just sitting below. Its appearances are of a bagel shaped mass. And if we can go to the next slide, that's fine. An ectopic is estimated to be picked up in just under 74% of initial scans in this paper, and this rises to the high 90s on further imaging and follow-up. The mass that is most commonly reported, as we saw in the last talk, is an inhomogeneous mass or blob sign. We can see that an image of that here, followed by a bagel-shaped mass, and then more advanced gestational pictures such as a yolk sac, and finally a CRL. And this last image is from a patient who presented very recently with very mild spotting and mild abdominal cramping. And these symptoms can easily be confused with threatened miscarriage. I wanted to discuss here that it is all well and good in services where there is good setup with high resolution ultrasound available and skills to use it. There have also been some papers looking at ectopics in lower resource settings, confirming that more commonly women present late and often ruptured, and ultrasound isn't always available, especially transvaginal and other modalities such as peritoneal aspiration is used to confirm hemoperitoneum. This review paper in Ghana showed that less than 6% of patients arrived with an unruptured ectopic pregnancy. In the Tanzania study, there were no deaths, but a significant morbidity with 1 hysterectomy and 7 oophorectomies done. And studies have also been looked at comparing transvaginal and transabdominal examination, which, although show that transvaginal have a better sensitivity, that transabdominal do have still a good sensitivity of picking up hemoperitoneum in the context of a positive urine pregnancy test, and also an observational study that was done under our group here, which looked at patients having transvaginal scan versus a handheld Doppler, which showed good comparability and close agreements, especially looking at CRL and mean sac diameter. Even if pregnancies cannot be visualized, it can be useful to look for free fluid and hemoperitoneum on transabdominal ultrasound. It can be seen either in front of the uterus, between the bladder and uterus, or between the rectum and uterus, or in severe rupture, high between the liver edge and the kidney and Morrison's pouch. If this is seen, it may prevent unnecessary paracentesis or cholecentesis, and an ectopic must be the diagnosis with a positive urine test in this situation until proven otherwise. Mayor, what do you think about the practical consideration for diagnosing management of ectopic pregnancies in these settings?
Well, Emma did a great summary, and like I said, there's so many factors to consider. So the specific patient factors, the ultrasound factors, and also the local factors. But I think, you know, as we're speaking today to people from many different countries in the low resource setting, and one of the challenges, I guess, is for your patients to be able to come back. Often patients have traveled from a very long distance, and of course they have to, if you are going to manage a patient expectantly or with methotrexate, should they're in an emergency, can they access the care and help they need? And obviously they need to be able to come back for blood tests, and it does take the resolution from expected management approximately 3 weeks, is what the data suggests. So these are very important considerations as to how things are managed. And of course, access to drugs, as Emma pointed out. Is there access to methotrexate, and is that easy to obtain? So I think sometimes local factors play an important role in a way deciding what happens, and maybe more surgery is done in a low resource setting, which is highlighted in some of the papers that have come out from those regions. But I think where possible, expectant management is a very good option, and it's been shown to be possible to treat about 30% of ectopics in that way. So I think if we can, it's a very nice way to treat some of these very small ectopics with low HCGs where appropriate. Shall we move on to the next case?
Let's move on to the 5th case. We have a 32-year-old patient who was postnatal. She was transferred from a district general hospital to our tertiary unit after having a vaginal delivery with a major obstetric hemorrhage and a 3B tear and an undiagnosed placenta accreta. The placenta was left in situ postnatally. Initial management was expectant with regular ultrasounds and monitoring. Within the first week, she had a fever and some bleeding, which was managed with antibiotics, and she improved, and her bleeding stopped by week 5. Week 7, she was readmitted. On the ultrasounds, there was a virtually empty uterus, but a possible mass seen below the cervix. On vaginal exam, a possible placenta was felt, however, the patient could not tolerate the examination, especially with her recent 3D tear and recovery, and therefore she went for examination under anaesthetic and removal of placenta. She came back at week 9 and had a normal endometrial thickness with no evidence of retained products of conception. As we discussed in some previous talks, the data on retained products of conception, whether obstetric or following a miscarriage, is not extensive. There is some data that expectant management can be good and it can be superior to medical management of misoprostol. And there is also some data of women who have had hysteroscopic treatment may have an increased incidence of intrauterine adhesions, especially in those who've had cesarean. But it's difficult to know whether these women had a more difficult post either delivery or post miscarriage course, and whether that could be a confounder. Do you have any thoughts on that, Maya?
Yeah, it's really managing retained pregnancy tissue is always very challenging. I think it really depends. You know, Thierry did a nice kind of summary outlining. It depends really on the patient's wishes, the patient's symptoms. So if they're bleeding very heavily, of course your hands may be tied towards a surgical procedure. If there's sepsis, of course, again, your hands may be more tied towards giving antibiotics and doing a surgical procedure. But where possible, in a well patient who's not bleeding heavily, it is very successful to follow an expectant approach. The data is variable, somewhere in between to 40 to 100% chance that it will resolve spontaneously. Again, the commitment there has to be that the patient's able to come back for follow-up and able to access emergency care should they become unwell. So that's also very important. I guess the other factor, and increasingly Prof. Bourne made the point about people being concerned about intrauterine adhesions. And really there's very little data about which patients with retained tissue will go on to develop uterine adhesions. The suggestion, as you rightly said, Alex, is that they could be associated with those who undergo hysteroscopic resection, but could those patients be already on the more severe end of the spectrum, having needed to go through that procedure? But I think we don't know. And as Thierry said, he always worries about those with sepsis, because he thinks that's one of the risk factors for developing adhesion. So I don't think we hugely know, but I think where possible and feasible, an expectant approach is very safe in the right patients. But where somebody is bleeding heavily or of course septic, you may be more inclined to do a surgical intervention.
Okay, Alex, I'm going to have to step in now as chair, because we're over time. If you could stop sharing, Alex, that'd be great. I'm sorry, I'd like to apologise to Martin. I thought we were finishing this session at 3:30, but it's actually 3:20. They were great cases, and I think they were really nice because they illustrated a lot of what we've been talking about earlier on in the session. So they were absolutely perfect, really, I think. So thank you very much for those. I know a lot of work goes into making cases. I hope that Alex, you know, it usually comes down to the PhD person who makes the cases. I'm sure, Mayor, you're doing. Go on, just admit it. Come on.
It's all Alex.
It's all Alex. It's all about Alex. It's all about Alex.
Yeah.
So thank you both. I'd like to thank all of our speakers. I thought it was a great session. Thanks, Emma. Lovely to see you as ever. Thierry for, well, you're working still, obviously. And I'd like to thank myself for a terrible talk. Sam, over to you if you want to just have a few last words, and we'll have a quick break.
All right. Thank you so much, and thanks for having me. Thanks everyone for joining in. And these were very important topics, for particularly in the raw resource setting, where we one of the things we struggle with early pregnancy complications. Just here in Malawi, I think a lot of maternal mortalities are attributed to things like pregnancy complications. And oftentimes we do see complications of miscarriage as well as ectopic pregnancy. And what you did explain in one of the cases is indeed true, that Sometimes the thought process is about what's outlined or what's available elsewhere. But when you contextualize in these settings with availability of resources, it becomes quite challenging. And thanks for sharing, and thanks for sharing your experience and how to approach some of these things.